Hello and welcome to this presentation. My name is Hans Nossent. I'm a rheumatologist based at Perth in Western Australia, and I'm presenting on behalf of my collaborators Warren Raymond, Helen Keane, Charles Inderjeet, and David Preen, all based at University of Western Australia. IGA vasculitis, which is today's subject, is probably better known under its old name, henoch-Schönlein purpura, and it defines a situation where leukocytoclastic vasculitis has occurred in the smaller blood vessels, especially the arterioles, capillaries, and venules of the vascular bed. This is all set off by the production of an abnormal or an amount or an abnormal type of immunoglobulin A, which is the main protective immunoglobulin in mucosal areas. This abnormal IgA precipitates as in the form of immune complexes in the small vessel walls and then sets off an inflammatory response that destructs the blood vessel wall and leads to the extravasation of red blood cells. This can be nicely demonstrated by tissue samples where IgA deposits can be shown by an immunofluorescence, leading to the inflammatory changes in the glomeruli here and in the skin here where the blood vessel walls have been destructed. Clinically, of course, this presents very much as a bleeding condition where significant purpura can be detected, especially on the lower legs, but sometimes on the trunk as well. Bleeding can occur in the gastrointestinal tract with quite severe blood loss, and macroscopic blood in the urine can occur when the glomeruli become inflamed and when the glomeruli become fibrosed as well. This will lead to loss of protein and the occurrence of pretibial edema and slowly developing renal failure over time, leading to chronic kidney disease and end-stage renal failure in some cases. IgA vasculitis is relatively rare, but in children it's the most common type of systemic vasculitis with an overall estimated international incidence rate of 10 to 20 per 100,000, and in WA, based on hospital data, we estimated about 5 per 100,000. Overall, it's considered to be self-limiting, usually occurring after an infectious episode, but it may require quite aggressive treatment with high-dose corticosteroids and cytotoxic drugs, especially when there's severe organ affection. We know that about a third of patients will experience a relapse in the first few years of the disease. And what is unknown is whether the abnormal IgA production is a one-off thing or it may actually be a chronic thing that leads to abnormal IgA deposition in tissues over time. And given its immune background, there's no clear data whether this predisposes patients to develop other autoimmune conditions. So we investigated, based on the above, the long-term comorbidity in patients with IgA vasculitis diagnosed in Western Australia. We used the WA Data Linkage system to establish a Western Australian rheumatic disease registry containing data from 4 linked data sets from WA Health. And we included about 250,000 patients with at least one of 28 predefined rheumatic diseases to help us overcome the standard trouble with rheumatic disease research. That is, now we would have large sample size, longitudinal follow-up, and accurate outcomes. We designed this as a retrospective case control study where we included patients when they had a diagnosis of IgA vasculitis based on ICD codes at the age under 20 years in the period 1980 to 2000. We used hospital-based controls, so not necessarily a healthy control group, matched for age, gender, and index year. And we looked at outcome measures in the form of comorbidity at last observation, as defined by the Charlson Comorbidity Index, which recognizes 17 separate comorbid categories, each given a weighted score, so an overall comorbidity score can be estimated as well. And this has been found to be a useful prognostic tool in a large number of studies. Given the chance of developing comorbidity, we also looked at hospital and ED visit rates over time in these patients, and finally looked at mortality rates and survival. We included 494 patients that had a first diagnostic code for IgA vasculitis and 1,385 controls, around 4 years of age at first inclusion, an overweight of male patients, as in all IGA vasculitis studies, and about a quarter of the patients originating from areas outside of the metropolitan area. Clinically, there was not a large difference between the symptomatology, but glomerulonephritis was more frequent in the IgA vasculitis group, as probably to be expected. The overall observation time was about 25 years in both cohorts. Looking at the comorbidity at the last observation, we noted a clear absence of cardiovascular events over the 25-year period, which may sound less surprising given the age of the cohorts. But in terms of vasculitis, it's well known that any type of vasculitis in the adult population will increase the risk for cardiovascular disease in the next 10 years significantly. So this is a reassuring finding in terms of the childhood patients, although we cannot exclude that they may be predisposed to the cardiovascular comorbidity at a later time point. We did find increased rates of peptic ulcer and renal disease comorbidity over time, which was to be expected based on the clinical findings and is largely in line with the literature. Notably, we did not see any change in the risk of rheumatic disease development or other autoimmune diseases like diabetes mellitus or liver disease. And last but certainly not least, we found a lower rate of chronic pulmonary complications as defined by the Charlson Comorbidity Index, which was a kind of a surprise finding, given that the abnormal IgA would usually predispose patients to more respiratory conditions. What this meant in terms of the hospital admissions and ED visits is shown in this slide, where we noted a slightly increased hospital admission rate in IgA vasculitis patients of 1.15. But that was largely due to a highly increased rate in the first year following diagnosis, while the rate following the year after has actually been a bit lower in IgA vasculitis patients than the controls. In terms of ED visit attendance, we found that IgA vasculitis patients do have an increased rate that is not only in the first year after diagnosis, persists for many years thereafter. In terms of comorbidity scoring, we found a very low CCI in both cohorts at the end of observation, and we found no difference in the amount, in the number of patients with any form of comorbidity between the two cohorts. When we looked closer at the reasons for the increased ED visits over time, the majority of visits was due to injuries, poisoning, and fractures in the musculoskeletal system, while the other conditions like skin, digestive system, and renal were largely comparable between the two cohorts. Finally, looking at mortality as an outcome, we found a very low mortality rate as expected in this young cohort, with a mortality rate ratio of 1.3 between the two. And when we compared IgA vasculitis patients to the WA population, the standardized mortality rate ratio was 1.7, which remained insignificant. In terms of overall survival, the 20-year survival rate was over 99% in both cohorts, with no significant difference noted between them. So what we learned from this study is that in children, the development of IgA vasculitis does not lead to an increased risk of other rheumatic disease or diabetes mellitus over the next 20 years. And that despite the increased risk of renal failure and peptic ulcer disease, with current management options, these children have an excellent prognosis, and these comorbidities do not reduce their prognosis over the next 20 years. The reasons why IgA vasculitis patients continue to have a higher rate of ED attendance is unclear, but might be related to either the condition itself or concerns of having a relapse of their condition. All this, of course, needs to be taken in consideration of the limitations of this study. Our study has a selection bias towards more severe disease in patients presenting to hospital or ED. Our hospital-based controls are not healthy, so we may have underestimated some effect size in terms of comorbidity. and the lack of clinical details is always a bit frustrating for a clinician like myself. So thank you for your attention.